We are moving on to Dr. Gilbert Tang from Mount Sinai to tell us about the promise and pitfalls of valve-in-valve TAVI. And
We didn't give you 15 minutes for valve-in-valve TAVI, did we? Let's keep it to 10. 5.
Did someone keep the clicker?
Who stole it?
Who was the last talk?
Someone clearly want to sabotage me getting the clicker away. And on that note, I think Dr. Adams just disinvited me for this meeting. But it's really an honor and pleasure to be here. Thank you. Yeah. That's right. So, I just want to say a few words about Dr. David. I first got to meet him more than 25 years ago as a first-year medical student at the University of Toronto. And I saw his operation. I went to tell my mom, I want to be a heart surgeon. I say, why? Well, I saw this surgeon do a very complex surgery, make it look so easy. I can do it too. So since then, I've been privileged to be able to train here and now come back to take a little bit different path. I want to give this talk because this is probably the only cardiology talk in the entire meeting. But I think as a surgeon, it's really critical to understand how they think, what they do, and what they publish so we can actually be better surgeons in terms of heart team discussions, because I think we need to add value to the team. And if we do, we need to know what they're doing and how we can counter that. So these are my disclosures. This is the reality in the United States. I know it's south of the border, but maybe a little bit different in Canada. But as people have said, TAVR is now more than 50% being done in the United States, and the number of cases are rising. So just want to give everyone a context of what the options are for failing bioprosthetic valve. Obviously, we talked about redo TAVR, valve-in-valve, but of course, we talked about also failed TAVR as well, TAVR explant and redo TAVR. So what this talk is about, this is not about, as I mentioned, why re-op TAVR may be better, because there are other discussions about that. I'm not trying to convince you why a randomized trial is necessary, but I want to frame the discussion a little bit differently so that you become more knowledgeable about the limitations and potential solutions in TAVI-in-SAV or TAVI-in-TAV. Be more savvy about what the procedure is about so you can actually talk to your cardiology colleagues about it, and also be more aware of the current literature. So this paper, I was involved with some of you here as well, showing that, in terms of matched patients in the United States, 3 states, based on codes, that TAVI-in-SAV has increased mortality after 2 years in heart failure. So definitely it's not the panacea, and you can see that here with the survival curves. But, I think also people need to understand, at least in the United States, I'm sure elsewhere in the world, it's really only in high extreme surgical risk patients. Now, obviously, that definition varies from surgeon to surgeon and institution to institution, but clearly there's been a creep. And I think as surgeons, based on the discussions here today, we need to really put our foot down and say that is the patient truly high or extreme surgical risks? The procedure itself technically are relatively straightforward, obviously to worry about the coronary obstruction risk. But the cardiologists are smart. They know how to do certain things to kind of mitigate against that. Now, one thing they cannot do is severe PPM, okay? So they cannot put another valve, like the Russian doll effect you saw earlier. But they now have some creative solutions. Some valves can be fractured to make them bigger. So, you have the way to root enlarge in the operating room, but now they can do it in the cath lab. And the 5-year durability they quote is reasonable, but of course it's not, because you can see it's 5 to 6% valve failure compared to some of the bioprosthetic valve durability data that you've seen. Now, severe PPM is a problem for valve-in-valve, and you can see this is very early data back in the VIV registry that if you have severe PPM, you have a high mortality. End of discussion. And you have a smaller surgical valve to start with, and you put a smaller transcatheter valve, again, it's going to be also impact on your survival. So patients need to understand this, particularly in younger patients, quote-unquote high risk. They're not high risk. So this is a registry data published by Edwards. You can see this is 5-year mortality. They are making intermediate surgical risk patient in terms of, obviously not matched, but certainly just in the survival curve. And you can see the bioprosthetic valve failure rate in terms of reintervention around 2.3% in 5 years. So compared to other surgical that you've seen earlier, both aortic and mitral, certainly it remains to be seen. And again, you can see that this paper, even with supraannular valve that's supposed to have quote-unquote better hemodynamics, it does increase to 5-year mortality. So here you can see that is not what it's supposed to say. This is a paper I published a few years ago on the technical aspects of valve-in-valve that I would encourage to read, not because you're going to necessarily do this procedure, but you need to understand what the vocabulary and language is about. And here's the other thing, Brad showed why the 2 TAVR explants fail, and you can see now why. So unlike a surgical valve, which have a rigid frame, TAVRs are mostly underexpanded, and that's why it failed. And also keep in mind, surgery, you take out the native leaflets. TAVR, you keep the native leaflets in place, so there's a sinus washout issue. That's why you see clots around the sinuses. You see that right away, and sometimes in procedure, you see a dark stain contrast in the fluoroscopy. So again, this is the reason why TAVR fail, and actually, if you develop this, you have high mortality. And this is a bench model, okay? So this is now normal leaflets. You can see that a lot of these valve-in-valve procedures, you can see on the left side, pinwheel. They're not a Mercedes-Benz sign you expect after a valve is supposed to put in. Now, people, as I mentioned before, if you can safely do that, you can fracture the valve. Not all surgical valves are fracturable, so as a surgeon, you need to know which valves are. And you can see it does improve it, but it's really not quite fully expanded. And this is the list from that paper that I mentioned before. Certain valves can be fractured to expand the valve area, but not all of them can, and some of them cannot. Now, how do they do that? The cardiologists, what they do is they basically use a balloon to break the frame, and these are plastic frames. You can see different atmospheric pressure. And you can see this in the example here. Patients that you can see we pre-fracture, we put in an evolute valve, and you can see at the end how it looks like it's better expanded than this rather than scrunched up. Now, there's been debate, do you do it before and afterwards? There's really trade-offs, but there are certain cases that you need to tell your cardiologist, don't do it. Okay, and these are the 2 situations. If you do the root replacement enlargement, even though the scar tissue, you disrupt the aortoventricular junction, you may actually end up having a pericardial effusion and tamponade. It's not risk-free. You can see this paper is actually quite understated, and I actually quote it every time because there are complications associated with this procedure. You can embolize the valve, you can cause acute hemodynamic instability, you can get coronary obstruction as well. Now, people try to modify the leaflets, but again, it's not a panacea either. So we've talked about some classifications on how to do it, when to do it, but obviously these are high extreme surgical risk patients. This European Heart Journal review talking about the sequencing of lifetime management, as people was mentioned before, but you can see clearly people are talking about more than interventions, and if you go to a cardiology meeting, this is kind of what they forecast in failed TAVR. Okay, so this is clearly going to be a problem for everyone here in the audience. And of course, we talked about this is the fastest operation. It's not just explant, but also failed TAVR. Talking about, for example, here, you can see a sapien and evolute. But of course, even though the early outcomes, quote unquote, in highly selected patients appear favorable, they actually in reality is much higher risk procedure than advertised. But I think you need to understand from a heart team standpoint how to evaluate these patients. And obviously, if they're operable, they should go for TAVR explant because you're not going to fix everything with another transcatheter valve like a Russian doll effect. And we published some of the pathways. These are just some examples how they might looked at on fluoroscopy and angiography. But of course, there are a lot of unknowns. As I mentioned before, it's a more complex operation. You can't avoid coronary obstruction. Anticoagulation need is still unknown. Obviously, there's a potential risk of second valve being underexpanded, and then you have to think about the coronaries after your second TAVR. So we've done some work in this. This is a paper that we go present in New York Valve in a few weeks and actually impress in JACC intervention. You can see that it's actually quite unpredictable how you do these procedures. So this is not for everyone. This is actually a highly complex and sophisticated operation. And this is another paper hopefully going to be also simultaneously published in JACC intervention and New York Valve, showing that the second valve are always underexpanded in this small series. So you saw earlier the first valve appear underexpanded. The second valve is going to be even more underexpanded, so you have to understand that. And unfortunately, no one talks about it, and so this will be quite provocative in the meeting in a few weeks. And of course, people try to compare TAVR and TAVR versus native TAVR. This is a Lancet paper that's published from Cedars using TVT registry, and they show that at least 3 years there's no mortality difference. But hemodynamic is worse. Gradients are higher. So you can imagine if you start a higher gradient and smaller area, guess how long these valves may last. There's no difference between which valve you pick in terms of combinations, but if you put the short valve and a short valve, meaning a sapien and sapien, typically you do have higher gradients. And of course, the combinations in other registry have shown that. Well, I won't belabor the point. And finally, people have not aware that when you put two valves in, bye-bye coronaries. Okay, so you will not ever will get back in. If you have a STEMI in the middle of the night, you're in deep doo-doo, shall I say. And I think people need to understand that because, people are kind of really simplifying it. We've actually looked at a registry with some of the groups here, looking at redo TAVR versus TAVR explant because, the mortality, at least early in the series, was quite high. But if you look at landmark analysis, they actually have the same survival curve. So even though TAVR explant may be having a high mortality, I think in the latest experience by Fukuhara and the group, I think it's down to 30-day mortality of 10%, so it's definitely safer and better. And I think we're smarter about it. We published actually a JTCVS paper on the techniques, but certainly I think we need to keep that in mind. So I think in summary, I think TAVI and SAV, in appropriate selected patients, is a relatively straightforward procedure as long as the coronary obstruction is low. The valve fracture can expand the options, especially in patients with severe PPM or high coronary obstruction risk. Beware of that. Redo TAVR procedure will rise in volume as TAVR becomes the default therapy. And I think that redo TAVR looks safer right now, but definitely higher risk and more complex and less predictable. And still, we don't know what the need for anticoagulation and durability. Thank you.
Gilbert, thank you so much. That was outstanding.